we start, sir?
Please, Ganesh is ready, we can start.
Yeah, the patient is a 20-year-old male. Yes.
Morning.
Morning.
I thought that today I would be in the line of fire.
I'm holding my fire.
And discuss a interesting problem which has been sent to me. As shown on the slide, that this is a boy with obviously spinal dysraphism, and he underwent surgical repair of that at the age of 45 days. At that time, the antenatal ultrasound showed a normal left kidney and a dysplastic right kidney. And the postnatal ultrasound showed dilated renal calyces and pelvis. Next slide. So it's pretty obvious from here that we are dealing with somebody who's got likely to have neurovesical dysfunction. It's quite obvious. And post-surgery, this child developed abdominal distension and urinary dribbling, which was persisting till about 6 years of age. Now, this is a very disconcerting situation because here is a child who has had, we know clinically, spinal dysraphism, and a situation like this should never happen, and this child should never have suffered to the end that what has happened right now. And recurrent UTIs which were managed conservatively. Many years ago at a pediatric conference I had gone, and I had actually said that I had presented some of our data from Bangalore on renal transplant in children, and they said that, oh, children can have transplant. So I had to raise my eyebrows and I said yes. So at the age of 6 years, the MCh was done, which revealed multiple bladder divertically, narrow caliber of the urethra, significant PVR and bilateral VUR. So it is evident that there was some problem here with the urinary bladder consequent to the spinal dysraphism and the meningomyelocele which this child was born with. Next slide. Now, due to the significant PVR and bilateral VUR, he was started on CIC. We have no data as to whether any other investigation was done at this point, except that he started on CIC. DTP was done in 2006 and it showed a preserved left kidney and a non-functioning right kidney. And at the age of 12 years, this boy's serum creatinine was 2.2. In 2012, April, somewhere middle of the year, he underwent a circumcision, a CMG and a cystoscopy. It's unfortunate because this, to my mind, this CMG, etc., is nearly 6 years too old. Anyway, that was done. It showed a grossly dilated posterior urethra, a tight sphincter, severe bladder trabeculations, and the CMG, we don't have record of that, but we know that it was reported as showing Detrusor Sphincter Dysfunction. Another common misconception that children who have sacral meningomyelocele will always have a lower urinary tract which is very safe and there is no high pressure and they're leaking urine all the time. Now we must understand that that does not happen in every case, and there are various shades of grey as a consequence to even a sacral deformity. So that's the reason why these terms lower urinary tract bladder and upper urinary tract bladder are sort of now relegated to the backbench. Next slide, please. This is a slide which shows what happened from 2012 to 2016 when there has been a sharp rise of serum creatinine. As you can see, every year it seems to be going up, and we are watching how this thing actually is unfolding. So just to summarize at this point, the child with spinal dysraphism being managed on CIC and slowly rising creatinine as a consequence of bladder dysfunction, which is probably Detrusor Sphincter Dysfunction.
Dr. Ganesh, can I ask a question? Can you go back to the previous slide?
Yes.
Yeah. So I want to emphasize on this point that you made, that just because it is at the sacral level, it is going to be a safe lower urinary tract. This is something that needs to be emphasized, because even now when people talk of a neurogenic bladder, they start from neurogenic problems right from the suprapontine level to the thoracic level, lumbar level, sacral level, and so on. We must remember that in the absence of intervention, all this holds good and is only a guideline. It is a guideline to the possible kind of neurogenic bladder that you can come across. Now, is there going to be something more than this? How severe? This applies to a time when we were not able to do urodynamic study, or now video urodynamics, where you will get all the information that you want about the lower urinary tract. So we should not be looking at the spinal level of a problem to say this is the kind of bladder that I am going to be seeing here. The second is, as you had mentioned in your previous slide, there is spinal dysraphism for several vertebrae. If that happens, I don't know if there was a syrinx at a different level, or when they operated, what else happened. See, surgical intervention causes a lot of disruption, especially if it is not done at the microvascular level. Several other contributions happen post-surgical intervention in these bladders, and it is very important that we understand this before we just go by the spinal level, which is what you have said. And the other is that we must look at lower limbs, the bowel function, as well as the bladder function impacting on the upper tracts. This is something that anybody who is going to be dealing with neurogenic bladder has to remember, especially in the pediatric age group, because you will see that they land up with end-stage renal disease very early in their life, completely preventable.
Can I add something?
Yes, Mohan.
The conundrum when we are dealing with neurovesical dysfunction in myelodysplasia and having bilateral VUR especially, is we are unable to assess whether the bladder is already high pressure or whether this poor void is entirely due to the so-called dyssynergia or large residue. Therefore, I think it is safer along with CIC to add anticholinergics right at that stage. To whatever extent the bladder compliance can be improved and pressures reduced will prove beneficial subsequently. Invariably, these children who develop high creatinine early in life will proceed to renal failure also early in life. So I think we should add anticholinergics along with the CIC.
I think that's a point very well made, Mohan. You don't lose anything at all by adding an anticholinergic. You don't need urodynamics. If you look at this boy's, the first line on this particular slide, high PVR, bilateral VUR. Now, this is a combination which speaks only of a poorly compliant bladder. So at that point itself, they should have started with the CIC anticholinergic. So we might have been able to prevent very rapid deterioration of the renal function. I know that he's only a single kidney boy, but having said that, I think we did lose a bit of time by not starting him on anticholinergic. So can we go to the next slide?
So one more. So sorry, sir. I have one question, sir.
Yes, sir.
Now, it is not necessary that if a bladder is safe today, tomorrow the same bladder will be safe. So how frequently should we have followed up? Assuming at 6 years it was safe, how frequently would you say we should have followed up, sir?
Once supposing at 6 years this boy had this picture, this first line on the slide, I would have put a big red flag on his chart, and I said that, this guy needs to be followed up a minimum of 3 times in a year, and to see what's happening to his creatinine, and more important, the serum creatinine, the GFR, the eGFR, hypertension, presence of proteinuria. These are things we don't even look at in urology, And I think it's very important because this patient belongs to us right now. And then either we send him straight to nephrology early on, or we say, okay, we look at this. After the horse is bolted from the stable, there's no point in doing anything. And Manish is absolutely right. This bladder picture changes dramatically over time. Becky also made a point that, with the surgery does cause a lot of disruption because there's adhesions of the nerves to the theca, and when they dissect, and some surgeons will not operate. They will not operate on them, and they'll say, "God, I've got a lady who's 50 years old who still has got that sacral meningocele sitting with her, and when you touch it, she gets severe headache because the intracranial pressure rises, and she's managed, she's married, she's got a kid, everything, and she's doing CIC with a single kidney, normal renal function." So there are situations where this can actually go completely south in some patients, so they are careful. Anything somebody else would say?
If I may, again, Manish, urodynamically, it is recommended that the next urodynamic study is 3 months after the first one is done. If the second one shows deterioration, it's time to act. We don't wait for further deterioration. If, however, there is improvement or there is a stable bladder compliance and contractility or absence of contractility, then urodynamics is recommended once in 6 months for children with meningomyelocele, and once a year for people with stably managed bladders who have spinal injuries. That's the urodynamic protocol.
I think it makes a difference if you yourself have been following up a child or a patient for some years, rather than somebody who's been referred to you, because you then have to start all over again. And you can make clinical judgment when you see such patients and say, okay, these are the questions you ask. You have to put a patient on CIC. Is he getting incontinent episodes? Why is he getting incontinent episodes? These are some red flags. Is he getting recurrent urinary tract infection? Now, we forget that poor compliance is a major reason for recurrent UTIs in people. And we think that, recurrent UTI, just pump him with antibiotics and he'll be fine. But, that doesn't happen all the time. So these are red flags. So you use clinical judgment. At the same time, we have to have a very, very careful eye on these kids who have to have their bladders assessed. Shall we go to
Dr. Dilip here, 1 minute.
Yes, Dilip, yes.
As Dr. Ganesh had rightly pointed out that hypertension and proteinuria are more often missed. As you said, a lot of times the deterioration of GFR comes in because proteinuria and hypertension are not managed properly. And as urologists, a lot of times we see only urine microscopy is looked at. Urine protein is not even looked at by most of the people. It just says urine. Generally, when you see urology notes, you see only urine microscopy. Protein is generally neglected. So it's very important that we start looking at the grade of proteinuria also, and very importantly, hypertension which is properly managed.
Dilip, just to rest your leave your mind at rest. In this class, Dr. Mohan is very particular about looking at the macro of the urine, the specific gravity, the albumin. So I think our residents here are aware, but I take your point.
But it doesn't reflect in the notes when you see the urology notes.
Yeah. Can we go to the next slide?
So one more point.
Yes.
Was there any lower limb affected? Or was
Yes,
there
no, he's got talipes equinovarus, that's it. But apart from that, clinically he's got a very loose anal sphincter. He's got lax sphincter. I didn't want to go into all the other clinical details just because of time. So, because there's still a lot more left to this child. So, in 2016, his creatinine goes up to 9.2. Next slide, please. And then he's initiated on dialysis in 2018. And at this point in time, he was being managed in Trivandrum by one of the nephrologists I know. And he sent him to me in 2021, just during the COVID peak for bladder evaluation. We had a window period last year when things quietened down before the second wave hit us. So at that point in time, I did a urodynamics. At which point, I think the slides are here. Can we go to the next slide? This was the urodynamics that was done at the point in 2021 when he came. Now, let me actually also tell you that personally, while augmentation is a great operation, I have some degree of diffidence in offering it straight away to everybody, because I have seen the consequences of augmentation in patients over time. And I think if you can manage somebody's bladder without adding bowel to it, it will be a great thing, because remember that once you have bowel, you have another set of problems if this boy is going to go for transplant. There are many issues that we don't understand. Having said that, there is no contraindication again to doing a transplant in somebody who's got neurovesical dysfunction. If you look at the books in the early years when transplant started, neurovesical dysfunction was a contraindication to transplantation. So, we have moved on now that we understand bladder function. So I looked at this bladder and I found that the capacity was good. He did have a poor compliance, which I thought could be managed by adding on CIC, anticholinergics and Botox. I was holding on to augmentation at this point. Anyway, he went back to I would like to have some discussion at this point on this CMG, whether my decision to hold back augmentation was right or wrong.
The parameter to look at when we look at the urodynamics is what the safe capacity is. That is about 20 centimeters of water, and that is reached pretty early here. You see, the first peak that we see after the filling has started, he's already reached 20 there. So, and then it raises, continuously goes on up, and he is trying to void towards the end. Now, when the safe capacity of 20 is reached, that volume should guide us about the need for augmentation or whether we can wait. If he's got a safe capacity of about 75% of expected bladder volume, then with anticholinergics, one could wait and look for the next event, that's the next urodynamics or the next urological event. If it is less than 75%, I think it's safer to do augmentation at this point, protect as much of the bladder and the kidney as possible, and opt for transplant whenever everybody is ready. That would be the way I would look at it.
Becky?
Yeah, I was looking at that. At 140 ml, he seems to have reached around 20 centimeters, which is actually not bad for somebody who is 19 years old. The point is, now this bladder has already become exhausted, according to me. He's able to generate detrusor pressure, but I think the upper tract changes have already set in, and doing too much in the lower tract now is really not going to help this boy. His bladder capacity is quite all right in the sense you don't have a very high rise in the pressure unless it comes to, what is that, Prabhu? 240?
260 is the bladder volume.
240, at around 240 you find that it goes up further, but still not the dangerous levels that I would think that is causing continuing renal damage.
You see, I have a point here, Venki. Beyond 140, there is overactive contraction right through.
Yeah.
And even the so-called voiding pressure, which we're looking at terminal bladder filling, is actually abdominal straining. You look at the abdominal graph, he's straining abdominally and generating the pressure, which again is an unsafe behavior for the bladder.
Given that, we must also understand that this child had bilateral VUR, am I right?
Yes.
I don't know the grade of the VUR, but if it is gross VUR, I would expect about 100-150 ml to be accommodated in the upper tract, in which case the actual bladder capacity will be less. That is something that we have to factor in, and lower bladder pressures may be simply because the significant volume is being accommodated in the upper tract. And MCU would have actually thrown light on the actual state of the bladder.
Any other points, Dilip, Manish, Bobby, any points to make?
Nothing.
No, sir, nothing.
Well, be that as it may, I decided that I will hold on to the augment at this point and put him on, and I sent him back to his treating nephrologist, and I said, this is what I would do. I would put in Botox, I would relax his bladder and put him on anticholinergics, and then he's already, creatinine is 9, he's on dialysis, and you can go ahead and do your transplant, and we'll take a call after that on what is to be done. Now, I did not at this point do a formal MCU when he came in, because for the simple reason that when he came in that day, it was bang within the COVID period, and I had not done a urine culture for him, and I know that these fellows, when they have this, will really go on. So he had to get back because the borders were really getting tight. So I think I should have done an MCU at this point when he came to see me with just for the urodynamics. So I would like to make that point here. So anyway, that's what happened. And then subsequently, next slide, he underwent a renal transplant.
So what was his output when he was on dialysis? Was he on CIC now?
No, his output actually, when he was actually on hemodialysis, output dropped significantly. While he was doing CIC, there were times when I asked him that his output dropped significantly, and some days he would only have some 10 ml, 20 ml while he was doing CIC. But strangely enough, even when he was on hemodialysis and awaiting his transplant, he did not have significant UTIs in spite of the fact that he was doing the CIC on a bladder which was relatively dry. Anyway, so he underwent a transplant. It was mother gave her kidney, and this was an ABO incompatible transplant. And it was done in Calicut in August 2021. And then the usual protocol, which is followed for an ABO incompatible transplant, was done. This guy did very well. His graft took on nicely, and he's currently on triple immunosuppression post-transplant. The problem then started after that. 3 months after the transplant, developed fever, vomiting, loose stools. It was obviously a sepsis. He was started on IV ceftazidime, avibactam, according to sensitivity. He had blood cultures and urine cultures growing multi-drug resistant Klebsiella. And remember, he was doing CIC. And every time this guy develops this fever, the catheter was put back in, his fever would settle down, catheter would be removed, and then again the drama would start again. And at each point in time, there would be graft tenderness and graft pyelonephritis, and the graft would take a whack. The creatinine would go up, come down. When he had these episodes of infection, the creatinine rose to about 4, 4.5. Treated with antibiotics and catheter drainage, it would come down to 2. So this seesaw arrangement was going on after transplant starting from 3 months. He also was found to have a querying prostatic abscess, and therefore he was started on oral levofloxacin. And then he was planned to continue IV antibiotics for 4 weeks and oral levofloxacin for 6 weeks, 3 months following the transplantation. At this point, I got a call from the nephrologist and said what to do. I said, this guy, just make sure how his CIC is. Now, I know that there are a group of, when I say boys, I mean men on CIC transplant who behave quite differently to girls, women after transplant who have got neurovesical dysfunction and are on CIC. I find there are some boys who develop severe UTIs, severe orchitis, lose their testes, and continuing to do CIC. So there are, not everybody gets into that situation. There are some. And we have to look at how CIC is being done by these people. So one of the things that I tell them is, make sure your bladder volumes don't go beyond 250. We have a problem here because, the graft functions well and they produce a lot of urine. They drink a lot of water, especially at night, so the bladder overdistends. We tell them to do overnight drainage. We tell them to use new catheters every time, and it becomes very difficult. It becomes a costly affair. When clean intermittent self-catheterization was started, it was not sterile, it was clean. And now if you look at the the NHS protocol, they give them about 100 sterile catheters for CIC. And this was what was done by Sir Gutman in Liverpool. And when they had these paraplegics, they would have these teams of people going around putting sterile catheters to empty their bladders. And that's how they managed to keep UTIs down. But we said, no, we'll do clean intermittent self-catheterization. And therefore, sometimes you may have to use sterile catheters, but it is an expensive proposition. So I tried that for this boy. I told the nephrologist, I said, this is what we should do. And then, next slide. Do you want to stop here and discuss it? We'll go back. Go back to the previous slide. Go back. At this point, Venki, Dilip, Mohan, Bobby, Manish, fire away, please. Are you there?
Yeah. The point is that since this boy has such severe infection, his lower urinary tract volume versus pressure needs a lot more attention. Obviously, there is an imbalance in his output, which would have changed post-transplant. Two is that he has this reflux, so I don't know what is happening in the upper tracts and whether we need to address the upper
The
tracts.
native kidney.
Yes.
Yes, I think Venki is talking about the native kidney, yes.
Yes, the native kidneys. Third is there is no mention of his bowel movements. That is something that I would still focus on because that's a critical part in causing UTI. What you said about this using sterile catheters was there, but now they have found recently, there's a nice review article in which they have found that other than adding to the enormous cost, and of course, they're talking of the plastic waste generated, because there are several billions being spent on sending a patient home on sterile catheters for every use. We found that it really hasn't made a difference to the incidence of UTI. So the point is, instead of looking at the catheter, we still need to do a lot more analysis of what is happening in the lower tracts, the bowel, and in the upper tracts to the native kidneys before we can decide on the next steps.
In fact, I advise a nephrologist that to put this guy on laxative, change his diet, and if necessary, teach him how to give a self-enema and clean his lower act. This is a very important point that we tend to forget, that all these bacteria are coming from the bowel. And there are some nice articles which relate on the pressure that is generated in the bowel. And they have shown that because the bladder is very close to the bowel, there's a transmigration of bacteria because high pressures which are being generated as a result of straining with stool. And this transfuses across into the bladder, and that is how they get this infection. Apart from the fact that there's another reason actually, that's through the bloodstream. But this is something that we have. And I remember very distinctly a patient in Kuwait, a diabetic. A diabetic in Kuwait would have recurrent raging pyelonephritis, and we finally did a colostomy for him because we said this is terrible. We did a colostomy and we started giving him colostomy washes, close his lower end, don't do anything, and that got rid of his UTIs. This was in 92, 93. And, so sometimes this bowel can be a very tricky issue as Venki has pointed out, and we tend to forget about it or, concentrate more on the other aspects. Anyway, he came anything?
Yeah. Whenever CIC is initiated or something changes and CIC is resumed, an important aspect is to see whether the bladder is being emptied completely. So if this boy, this is theory of course, if this boy was emptying 150 ml before the transplant every time he did his CIC, post-transplant his urine output would have increased. He might have stopped or withdrawn the catheter at 150 and left behind a residue. This is something which is better followed up when he's still in hospital than later. Quite often we have found that it is this inappropriate or inadequate catheter drainage in CIC which is the cause of recurrent infections. So that's another point I'd like to bring up when we manage children like this or a young man.
The other point is an ABO incompatible transplant with generally immunosuppression is much higher. Yeah. So even with minor, the incidence of infections are likely to be much more in these patients than people with an ABO compatible transplant where the immunosuppression is, it's a triple drug immunosuppression. Here induction plus rituximab plus heavier immunosuppression for these children.
Point well made, Dilip, and I think we need to remember that rituximab is a good drug, but it really knocks your immune system to such an extent. Yep. Okay. Can we go to the next slide? So this, after a lot of toing and froing and all that, I told the nephrologist who I know quite well. I said, just send him. I think we need to step in here at this point. Otherwise, we're going to lose this graph. He's a very pleasant young man and very nice family. And they have landed up here yesterday for evaluation. So right now what you're seeing is the most current MCU which has been done. And, you can very clearly see, number one here, that there is a problem in the region of the sphincter, the prostatic urethra, the RGU and whatever is showing some sort of a disorganization there. It's trying to wide actually in that extreme left. What is more interesting here is there is reflux into the graft. There is reflux into the graft, and there is no reflux into the native kidneys on this current MCU. And as you can see, there's a lot of bowel loading. There's a lot of bowel loading here. So we have a situation here where there is graft reflux. There is a problem at the level of the distal sphincter, and we know that because he did have sphincter dyssynergia. But that area where we see the prostate, to me, looks as though it has been badly dealt with or traumatized. So I asked this boy, and actually Bobby saw him doing CIC, and Bobby mentioned that this guy's CIC technique is a little wonky. I went back and asked this boy, and he said, I have difficulty, and this is something that happens in people who have DSD. The sphincter is so tight that when they try to catheterize, they traumatize themselves, and they have to do some screwing maneuvers there. So sometimes they get it in, sometimes they don't get it in. And I think each episode of trauma in that area has not only resulted in probably bacteremia and has aided and abetted by the presence of reflux into this graft. So I think this was a double whammy situation here, and I'd like comments from the pundits on the other side. Venki.
Yeah. See, in this, his bladder at 250 ml, the bladder pressure still seems to be quite high. It is uniform, it's spherical. Severe bladder neck hypertrophy, in addition to the external sphincter problem, I really wouldn't pay any attention to the reflux at all. It has been my philosophy that reflux by itself is not the cause of infection, and we've had that several of our patients where we just manage the bladder pressures. This child, or he's no longer a child, this boy will need better bowel management as the first step. If it means daily enemas, so be it, because I don't know how this neurogenic component is working on the bowel. The other is that we really need to look if it is just a sphincter dyssynergia, or is there a stricture that has developed in that point now. And third, of course, is we'll have to repeat his urodynamic study, especially if there is no upper tract, the reflux into the native ureters. I would like to see whether it is obstructed now for any reason. Unlikely, but in a high pressure bladder, there may be a functional obstruction to the upper tract, and we'll have to see at what point of filling does this pressure rise to a point where it can cause upper tract obstruction and therefore be one more contributory cause to his UTI.
Looking at the first image, even at 100 ml, there is reflux into the graft kidney. So that is an alarm bell about the compliance of the bladder or its ability to hold it, unless the anastomosis itself is a refluxing anastomosis. The second issue is, I think it would be pertinent to do an ultrasound to look at the native kidneys to see whether any urine is being retained in the native kidneys, and that is the cause of infection. The third point I'd like to make is when we look at the prostate itself, it seems to be replaced by a cavity. Whether it was the abscess that eroded the gland or whether there are multiple cul-de-sacs resulting in a cavity-like appearance is something an endoscopy alone will be able to tell us. So if I were to look at this child, I would do an ultrasound of the upper tracts first. I would do endoscopy to make sure that my urodynamic catheter enters the bladder properly. And if there is no infection, under antibiotic cover, do a urodynamic study to assess what the bladder compliance is and whether there are still unstable contractions, which could worsen the reflux progressively.
So I would say, add one point that during scopy, if we find that bladder neck and the prostate is not, only add a BNI also.
Well, I think at the moment, the two examiners on the other side, I have passed. So let's go to the next slide, because whatever they have suggested, I have done. Go to the next.
Sir, I have a question again, sir.
Right.
You have already put this child on oxybutynin.
Yes.
But suppose this child had come today and I put him on oxybutynin today.
Yes.
When should I go and do a urodynamics?
Well, I would have done a urodynamics before I put him on oxybutynin, because I want to know whether that by itself is enough. Because oxybutynin will not be useful for everybody. So that's why while I do start anticholinergics with somebody, this boy was on that, I think we still can miss the bus. And when we did this MCU, we noticed this reflux. And we know, as Venki said, that graft reflux is a very contentious issue. This is a problem that has been faced by transplant physicians and nephrologists for years together. There is enough data out there. The latest article is only in 2008. After that, I think this whole issue has been laid to rest, and they have looked at grafts with reflux. You know, it's very difficult. They have actually done studies where they have, at the outset itself, done MCUs on these on patients who've had renal transplantation, categorized the result, the graft, the reflux category, and they have shown that actually there is no difference whether the reflux is of a high grade or a low grade. So Venki's point is well taken, that graft reflux by itself is not a reason to get alarmed about. And I recall that in Vellore, during all the transplants that we have done, there was probably only one boy who had reflux graft pyelonephritis, and we lost that boy. And late Dr. Shastri would never forgive me for that, because I said, to go back in, this fellow, so, he gets good episodes. He said, no, go ahead and do an anti. And we were doing we were not doing a refluxing ureter. We were doing an anti-reflux all the time, the Roy Kahn technique. So, that was the only case that I remember where we lost the boy as a result of sepsis. So, move on to the next slide. So when this boy came, we did this, and then I said we must repeat the urodynamics. And this is the current urodynamics in this boy.
Yeah, quite clearly the bladder pressures have settled down. He is generating his voiding.
No, this is not. No, this is not voiding. This is just a detrusor overactivity. He is not yet started to void.
But why is the rectal pressure going up?
No.
If we look at the bottom line,
rectal pressure is not gone up.
Okay.
Yeah, that's not the rectal
That's
pressure.
the rectal pressure.
You have to look at the top line and the middle and the third line. Top line, that's
Yeah.
The round one is PF.
This looks like overactivity.
Yes, it is that's what I thought. It's a, NDO, Neurogenic Detrusor Overactivity. And I think there is at the peak of that, there's a little bit of a leak. I think just at the
Yeah, he is leaking here.
And then there's some leak. So maybe, there's a little bit of dropping in pressures, which is keeping this bladder. But you can see that between the pre-op CMG and the current CMG, there is an improvement in this boy's bladder in terms of its compliance, and that is probably related to the anticholinergics which this boy was taking. But having said that, now we are faced with a different situation. Next slide. This is the voiding. I think, Venki, do you want to make a comment on that CMG? Venki?
No. I'm okay with that. Yes.
Okay. So now, is this the last slide or there's one more? Yes. Sorry. This is the transplant ultrasound. As I said, we've answered the question that the examiner said. This is the transplant ultrasound, and we looked at the native kidneys too. Right kidney is barely visible. You can hardly see it. Next slide. This is the bladder now. And these were the issues. The left kidney is seen, but there's no, as you said, there's no urine contained, there's no dilatation, and the right kidney you can hardly make out. The graft is on the right side. So these were the issues that are worrying me in this boy. The current creatinine is 2.2. What's the eGFR?
40.
eGFR is 40. He is otherwise well preserved, and this is the creatinine that is at the moment. And before he gets another episode of UTI, I think we need to try to hold back his creatinine at this point. I don't think we are going to get any more mileage from this kidney. Dilip, what's your view?
I think there's been enough infections and probably it's already scarred, So just have to make sure that there's no further infection. Whatever has happened is probably going to leave the GFR at that.
So, this is are the issues that are worrying me at this point. Is VUR into the transplant kidney an issue? I think Becky has said it's not an issue. I also feel at this point in time it's not an issue. Mohan says that it may be a refluxing ureteric anastomosis. And we also know that if the bladder is trabeculated, it can be extremely difficult to do an anti-reflux ureteric reimplantation in that situation. And we know that this bladder is on his old MCU showing gross trabeculation and sacculation, etc. At which point the transplant was done. Does CIC cause recurrent UTI? I think it does. Clean independent self-catheterization does pose a risk of UTI in anybody. And we know there are many reasons, and I think this particular boy has enough reason for him to get recurrent UTI. The question now is, how can we prevent this boy from getting recurrent UTI? Should I go ahead and do an augmentation? Or should I use Botox and anticholinergics and prevent him therefore by doing CIC by adding a mitrophanol in this situation?
Sorry, can you repeat the last line?
A mitrophanol. To prevent him from doing CIC and traumatizing his urethra, which may be difficult for him. I mean, he does express sometimes that I have difficulty in trying to catheterize, and he does some juggling around, and we found that there was his technique was not absolutely right, and maybe we need to prevent him from doing this, and whether we can do a mitrophanol for him at this point. We need to remember that his creatinine is 2.2 with an eGFR which is just about baseline 40. I have my own views and I'd like to hear what the pundits have to say. I can tell you what my views are, and you can agree to disagree or agree to agree, whichever way it is. I am worried about, again, I am quite happy to try Botox on this. I've done it before. So, Botox will definitely drop the pressures. The current CMG is not as dangerous as I would have expected it to be. And therefore, I don't want to add bowel because that is going to very quickly knock off his renal function with absorption. So therefore, I would like to try Botox to try to reduce that, continue with anticholinergics. And I'm very keen on mitrophanol, but I want to use his left ureter as a mitrophanol and not use bowel at all because his bladder capacity is around 260. Take off that left kidney, which is useless, and use that ureter, which is already reimplanted. There is no reflux in that ureter on the latest CMG, but we'll have a look at it when we do a cystoscopy. But this is what is my line of thought. So I'd like you to either shout me down or give your viewpoints, and we can discuss that. We still have 15 minutes, so.
So
Can I start, sir? Oh,
just
sorry.
1
Yes,
minute.
sir.
Currently, should we just leave the boy on a continuous drainage with the catheter? Is he on or?
Dilip, he has been on this for a long time. In fact, right now for these tests, we have removed that catheter, but this boy has had endless months of catheter drainage. It's been going on for 3 months, 2 months like this, and I'm only worried about orchitis. And then once, these guys get orchitis, they lose their testis, and another episode of UTI. So he's lucky that he did not have significant orchitis, but the catheter can get blocked. All sorts of things happen. So continuous catheter drainage is. I am personally not in favor of it because I don't know whether this boy will be able to manage, and that too with a bowel like that. I'm a little concerned.
The concern to me would be how good the submucosal tunnel will be for a Mitrofanov. Experience is that a lot of these patients who have long-standing neurovesical dysfunction due to myelodysplasia, you can't easily separate the muscle from the mucosa. There is a lot of interstitial inflammation. So a submucosal tunnel may be difficult, and the Mitrofanov might actually end up as a Benchicron procedure. Though we wouldn't call it so even if you are using the opposite ureter, because the opposite ureter was also refluxing. Augmentation.
Currently, Mohan, it is not refluxing now. It is not refluxing now. It is not refluxing now.
It's not refluxing now, right?
Yes.
Could give it a try, because the only chance we've got now is for him to stop using the urethra and use something else for catheterization. If that is reducing the episodes of infection or eliminating infection completely, we could wait and urodynamically evaluate him. And Mitrofanov will not interfere with urodynamic evaluation. So that could be a reasonable option.
Can I have a try, sir?
Sorry?
I'll have a go at it, sir. So for this child, if you're thinking of Botox and CIC is an issue because of the sphincter, we could give Botox to the sphincter and to the bladder and then put him back on CIC. And an option which is not here is a short segment ileal conduit and forget about the bladder completely. So those would be the two things I would think of.
That means take out the transplant ureter and this thing, or what are you suggesting we do an ileocystostomy?
No, sir. Just an ileal conduit. Transplant ureter into a short ileal conduit.
Instead of that, Manish, why not just take a segment of bowel, connect it to the, because the bladder will then be a focus of pyocystis. You have to do a cystectomy. You can't leave that bladder. And therefore, in these situations, it's always better to take a segment of bowel, attach it to the bladder, and bring that segment out as an ileal conduit. So it's an ileocystostomy. It's a great operation. It's a great operation and avoids all the problems of this thing. So that is certainly one option in a boy like this.
So it's a cystostomy with a ileal stoma, sir?
Correct. You open the bladder on the dome and then take this segment of ileum, patch it on like a cap, and the other end you just bring it out as a conduit. That's all.
Okay.
It's a great operation, and because this guy is not going to leak from below. He's got no, even if it does leak a little bit, it doesn't matter. He can manage with the diaphragm. It's a very useful operation in patients who got borderline renal function. Cystectomy could be an issue in terms of its morbidity, because pyocystis occurs in 40% of patients who have their bladders retained for various reasons. So it does become an extremely tricky issue in these patients to go back in later and do a cystectomy because of pyocystis. So, if you want to do it, this is one alternative. But
that is the Benchicron procedure, where you bring it directly out of the bladder, a short segment, fold it on itself to reduce the caliber of the segment, and use it for catheterization.
Venki?
Yeah. Couple of things. Has the bowel been attended to?
In a way, but not. I mean, that is going to be a long-term procedure. It's going to be a long-term procedure in terms of attending. I mean, we'll have these. He's a boy who will understand. And when I did a rectal exam, there was no loading of the rectum. There was no fecal impaction, etc.
Okay. Yeah. So that is one. Second, there are a lot of decisions that will be made based on a few presumptions. So, VUR, is
I
it
like that word. I like that. It's
Assumptions based on presumption.
So whether VUR causes infection, I've already said no, it has been shown that it doesn't. There is some other contributory cause that helps VUR carry infection to the kidney. Secondly, as Dilip has said, if our focus is to retain the GFR that we have now, we will have to also accept that there has been some amount of scarring or chronic pyelonephritis in the graft, and therefore it will follow its own inexorable course of reduced GFR over the years. This is something that they will have to understand no matter what we do. CIC, does it cause UTI? CIC doesn't cause UTI. If CIC were to cause UTI, millions and millions of people across the globe would not be doing CIC. It wouldn't be such an established procedure. CIC gives in an inoculum into the lower urinary tract. It is the local conditions there which actually turn it into a active UTI. Can you try Botox? Certainly, Botox can be tried, but I think in this augmentation, no, I'm not in favor of augmentation. Mitrofanov, I don't think it is going to make too much of a difference. Again, we are presuming that the damage to the external sphincter trauma is what is causing all this infection, and that using a different route is going to make him infection free. Point is, do we have a favorable lower urinary tract? Right now in his CIC, we know that around 220 ml his bladder pressures rise. So has he been able to do CIC to a point where he is maintaining the volumes to this level, to this safe capacity of the bladder? That is a very critical point, whether he does it through the urethra or whether he does it through the Mitrofanov. I agree with what Manish said, that we need to really address the external sphincter and the bladder neck. If a Botox to the external sphincter doesn't give him relief, then I wouldn't even mind doing a sphincterotomy, because the bladder neck is still there to provide him adequate continence. Despite all this, are we certain that we will prevent his further infection? May be difficult, because his bladder capacity has already reduced, and we will have to be prepared for persistent or recurrence of his infections, which is going to be very disappointing to the family, especially when you perform another procedure, giving them hope that, yes, I'll do this and then his infections will stop. We have to be very careful about what or how much we promise them. The alternative, and a very good alternative, would be an ileal conduit, or simply attach, whichever way, either attach it to the dome of the bladder, which I think is very good, or put in an ileal conduit. Making an ileal conduit is going to be even more difficult than simply putting in a small segment of ileum to the dome of the bladder, put in a urosac and the urostomy, and then leave him alone. We will do the bare minimum, and he is assured of a far greater assurance of stoppage of UTI than with all the other procedures.
Supposing, of course, that the advantage of using an ileocystotomy is that you have to some extent also added some volume to that bladder to reduce its pressure for whatever reason, the bowel. But yeah, I think these are very good options at this point in time. Personally, I am very concerned, because I have had endless phone calls on this boy from the nephrologist that, they're at the end of their tether as far as UTIs are concerned. And I don't want to let him go without doing anything at this point. I may be jumping the gun, but since I am not directly in control of this boy's renal function and his follow-up, there's a tremendous amount of pressure. I won't call it pressure, but I think we have reached a point where this conservatism is not going to work any longer. This boy has suffered like anything with recurrent UTIs, and the nephrologist is climbing the wall there. So, and it's not even a year since this boy has had his transplant, 21 August, and we are still only about 6 months down the track. And I don't know whether I'm jumping the gun, but I want to do something at this point for him. I don't want to let him go.
Looking at it from a very...
Bobby has some points to make.
So I think I agree with all the points made till now. one of the things which I came to know from a brief talk with the patient was he had leak, urge incontinence, when his dosage of oxybutynin was suboptimal. One of the things I am concerned is that whether he is compliant with medication. So we should proceed with this conservative treatment and also look at whether we can increase his compliance by changing his anticholinergics. Because he was actually on thrice daily oxybutynin. So we need to look at how to improve his compliance in that matter. To go ahead with Botox, and at that point of time, to do scopy, as Dr. Mohan was suggesting, to do scopy, that take that opportunity to look at the prostatic fossa and see what is the difficulty the patient is facing. And maybe at this point of time, whether if we can smoothen the cavity to facilitate CIC, we should do that. And just put these other facts of all the others into one basket. So that's.
So the other point I wanted to make is with this sort of repeated infections, we have had patients where the cause or effect we don't know. We have also had vegetations in the cardiac valves as a result of continuous bacteremia, which will also be sealing the bacteria. And other thing is we have had in some of the patients is severe uveitis, with recurrent pyelonephritis. The bacteria goes and lodges in the uvea, and we had patients, a couple of patients who lost their vision because of uveitis also. So it's not only urinary, let's start looking at other areas of seedling of the bacteria, the sort of recurrent infections. I don't know whether he had a central line or AV fistula prior to transplant.
No, he's got a working fistula at the moment. He's got a huge fistula. It's like one of those socioid aneurysm types. You know, it's quite large. It's a very good functioning, and it's something that at the moment with the creatinine 2.2, I don't want to touch that fistula. You know, anytime he might go back on dialysis with a graft which is ABO incompatible. So that's my worry.
So we have not seen the CIC charts, whether its volumes are very large, especially in the night, and whether because of UTI, everybody would increase the intake, and its capacity is around 200 to 240.
Yeah, you're right, absolutely, Prabhu. I don't have a CIC chart, but talking to the boy, this is what it is. And this fellow is doing a CIC, and he knows that when his bladder, because even during the CMG, when the bladder was full at 250, he was very uncomfortable. So he knows that his bladder fills up, and at night he puts a catheter and he drains. But certainly, and it's now 8 months since his transplant. For of these 8 months, there have been nearly 5 months when he's been on continuous catheter drainage. So every time they remove it, start again, bang on infection and all that. So yeah, I think the point that Bobby has made is also valid. Look at we have never looked at his urethra. Put the Botox, look at his urethra, and see whether this boy can redo his CIC. Even if he has to have an ileocystotomy, it's an operation that can wait and be done later on also, once the lower tract is cleared. Whatever it is, an operation is an operation. I'm not too worried if it refluxes with the ureter, because if you're going to do an ileocystotomy, it'll be an incontinent one. It doesn't matter, you can put a bag on this mitrophanoff and let it drain because if the anti-reflux is not good. So I think we do have enough options, but the message in this particular case is that, this is a tricky situation. And as I said, what Venki said is very clear, that the relatives, the parents, and everybody expect magic at the end of the day. That everything will be fine, there'll be no further UTI, and this guy's creatinine will improve. I don't think that's going to happen at all. And this is something that we must be aware of and counsel our patients, the family, that, this is a very difficult situation.
I'm not being cynical, but I also think we have to keep the feasibility of a second transplant in mind, and whatever we do shouldn't be compromising the chances of a second transplant later on if this kidney graft deteriorates. The problem with
And with
ASL,
that in
you mentioned
view,
on
with that
the
in view, certainly, with that in view, certainly we need to look at his lower urinary tract. There's no doubt about it. I mean, there's no question about it that we need to. Yeah.
So I would be very concerned about such a patient going back on a CIC in a city which in outstation. So one is this child will definitely need daily enemas. Now that is a commitment which the child and the parents have to give.
He's a big boy now. He's a 20-year-old fella now.
Okay. So I don't see a 20-year-old agreeing to daily enemas. But it is compulsory for him. He has nothing else will work, sir. Second is we have to be able to monitor his CIC volumes, which again becomes very difficult. Things like hand hygiene and all, we can teach him once and send him. But CIC volumes, socially keeping it below 200 ml is very, very difficult if he goes to college or whatever. So considering these two limitations, most patients are not compliant with enemas and most patients cannot keep their CIC volumes below 200 ml. So keeping these two things in mind, I would still favor some very aggressive treatment like an ileal condom if we have to protect the kidney.
Point well taken, Manish. Anybody else? Opinions?
Yeah, I agree with what Manish has said. You have two paths in front of you. One is, do I go step by step, still trying to get that holy grail to prevent this UTI, and then ultimately end up with some form of a diversion? Or do we say, look, we've tried enough, even if the boy is non-compliant with his drugs, he's non-compliant with CIC, he's whatever, the point is that you cannot blame the patient itself finally saying this kidney packed up because he did not do all this. So two ways to approach this. One is, do I go step by step and try to educate this boy, counsel him and do whatever, presuming again, as I said, that what he's doing is not right. Or straight away go and do an ileocystotomy so that the bladder pressures come down and hopefully his recurrent UTI will stop. Never mind the lower urinary tract, never mind anything. Just keep him safe, for which I think he will need a second transplant at some point of time, sooner than later. Of course, how the family approaches it. This is the decision that will need to be made in this, and I think that it is discretion is the better part of valor, where you simply say, look, I think we've done enough, especially as you have mentioned, he's not with you, he's in another city under other doctors. He may be better off with a simple procedure that will simply drop his bladder pressures, make life easy for the boy. And as Manish said, if he has to go to college or do whatever, life becomes much more easy for him.
I am also of the opinion that I'm not going to do anything conservative now. I've been in touch. It's just not that I've not been in physical touch with them, with this boy as a patient coming to the OPD regularly, but I've been in constant touch with the nephrologist, and we've had endless phone calls, and I know that he's up his tether, and something needs to be done at this point so that this boy does not have it. I feel that I need to do something. I can't just be conservative. And what I was thinking in my mind was, when we scope him, put the Botox and use that ureter, simply because I have a mindset about this bowel and tacrolimus and all these drugs and everything. Although it's a freely draining, yes, it's a conduit where it drains into another bag. He's got his transplant on the right side. We'll have to put the conduit on the left side. If you're going to have another transplant on this boy. So those are the issues which are there. And I think, as Venki said, ultimately the buck stops with you. You got to make that decision. And this is where things are very difficult in reconstructive urology. There are endless ways by which you can skin a cat, but ultimately the buck stops with you. Tomorrow you make the decision. I've done an ileocystotomy, and fine, if the patient doesn't want it, sometimes you can force him and say, this is what it is, you put a bag on. Or you bite that bullet and say, I take this kidney out, use that ureter so that I don't have any bowel segment inside. And use that ureter as a metrophenol and either as a cutaneous ureteroscopy, let it drain out completely from the bladder. He doesn't do CIC through his intestine. So, that's the way to look at it. And I am not in favor of sending him back with more anticholinergics, more CIC, this, that, everything. I personally want to stop CIC on this boy. That's the way I'm looking at it. So
that would be a good starting point.
Well, in a couple of weeks, I'm going to discuss another interesting problem, and I'd like the learned gentleman on the other side also to be participating.
You're becoming far too British in your later years.
Anyway, thank you very much. I think you've just overshot. And thanks, Manish, for
Sir, one question, sir.
Everybody on board. Thank
Hello?
you.
Sir, Vinod has a question.
Hang on. Any other question?
Sir, why ureter is used as metrophenol, how will it get vascular supply, sir? In the sense, if you disconnect the ureter, especially lower part,
We are
doesn't have much.
discussing. No. We are disconnecting the upper part. We take the kidney out. Don't disturb the lower ureter, and just bring it out as a metrophenol. I've done it. It works, and it's a reasonable option.
Okay, sir.
Anything else?
Thank you, sir.
Thank you.
Thank you,
very much.
Thank you. Interesting case. Good learning points. We'd like to know what happens. Of course, you'll tell us in course of time.
Yes, I will tell you what the decision we made. I'll record the Scopy findings, etc., and then we'll take a call. I'll definitely give you feedback. If my decision is right or wrong, you will know. Thank you.
Yeah, thank you all. We'll catch up next week. Nice to have Rinki around.
Yeah.